So, Diana, what are the key takeaways from View 1 and View 2 extension? Are you seeing, that, we have to do this sort of regimen with our patients where we give them a period of mandated dosing and then go to Q2 months, or a capped PRN, for example? Or how do you kind of take it back home to your patients?
I think it's a similar theme, what we've touched on before, which is avoid undertreatment. And in this study, it was because they had some mandated treatments. And I think in real life clinical practice, it's either employing a treat and extend, where you extend the interval, but that when they come back, you give them a mandatory treatment to avoid missing a sign of activity. And I think as long as you follow the patients closely and treat them, they can have a great chance of maintaining vision.
Yeah, and I took away the same sort of thing in a sort of a support of treat and extend for the first time, right? Because I'm not a treat and extend person, I'm a PRN person. And I'm probably the only person in this room who's maybe a PRN person, because I'm the limited one of the few that do that sort of thing. And I think that the capped PRN makes sense if you think about it from a treat and extend perspective, because that's kind of what you're doing in a capped PRN approach, is you're increasing the dosing you're doing and also making sure that the patients get their drug.
I've always thought of PRN as treat and extend with 4-week intervals, right? So we can all play the same game.
Yeah, absolutely, absolutely. What else do you take away from this, Lloyd, in your own patients for View 1 and View 2 extension? What did you think was the most important thing for
I think if you're
patients?
trying to take care of these patients on a sort of personalized level, what I think when you look at these two trials together in context, patients in the View extension got twice as much treatment in the chronic phase on average as patients in 7-Up, and we'll see that in range as well. And so I think what it tells me is that on average, probably 2 or 3 injections a year is not enough. And I think that we need to start shooting for, on average, a little more aggressive therapy. Now, understanding that some people may require much less.
Quan, we have some drugs that are going through trials right now. They might be every 3 months. And so are we going to, you think, get to a point where we go beyond the time periods we have? Or how do you foresee the future of this going?
Yes, certainly. I think the duration of the drug, if they can last longer, that certainly help with the burden of the patient and of the treating physician as well. But I think one of the key messages we have learned is that, yes, one would like to extend and use a drug less frequent, but one needs to monitor the patient as well. Because if we go into the mentality that say, we can treat every 3 or 4 months and the patient develop recurrent disease, that's not very appropriate and very beneficial for the patient. So therefore, yes, we know in the horizon there's several mechanisms of drug on various pharmaceutical companies are developing this drug, but still the caution would be, you may think that the drug may last that, but the period we still need to prove for ourselves and show that truly in real practice that is actually maintained. And Lloyd has used the term individualized medicine before. So each patient may have a different course either. So for Mrs. Jones, it may be every 4 weeks, but for Mr. Brown, it may be every 9 weeks, for example.
Yeah. And I pretty much tell the patients I'm going to get to know you very, very well over the next coming years, because we're going to be seeing them so frequently. So Lloyd, the range study actually was something that you worked on quite closely. Could you walk us through the range study?
So we've talked about the View extension that Quan presented at about 320 patients from the original 1,200 in View 1. So we went from 1,200 to 300 in the first phase of extension, and the range study is essentially an extension of the View extension, where a total of 6 sites that participated in View enrolled patients coming out of the View extension to follow them for more longer-term safety and efficacy data. And so the primary outcome was a proportion of patients that basically maintained vision, lost less than 5 letters from baseline of the range study, not from View 1, but from the range study out to year 1, and it was, of course, a 2-year study. And then there were a number of other secondary outcome measures, both functional as well as anatomic.
So Lloyd, can you talk about the summary of the results from the study?
Right, so we enrolled 35 patients. Mean age was about 68 years coming out of the View extension. It was predominantly women, presenting mean visual acuity was 61 letters. And the retinas were quite dry at enrollment, so these eyes had good disease control at presentation with a central subfield thickness of 216 microns. You see the treatment burden on the right of the slide, where patients got a mean of 8 injections in the first year, and that really has to do with the way the treat and extend protocol was put together. There was a mandated period over the first 8 weeks where they had to get more frequent injections, and but you see at the bottom that the distribution of injections was quite broad, and again, sort of owing to this idea of personalized disease and personalized disease management, but on average, about 43% of eyes got 7 injections during the first year utilizing a treat and extend regimen. In terms of visual acuity and the primary outcome, the patients that had their vision was well maintained from the baseline of the range trial at 61 letters out to 61.8 letters at a year. So really actually stabilized, really no difference at a year. So stabilization of vision. Here is some functional outcomes. At a year, we had 60 patients that didn't lose any vision. We had 15% of eyes actually gained 5 letters of vision, at least 5 letters. After 5 years of therapy, which is really surprising. And we actually had 2 patients that were big gainers. In terms of vision loss, 20% of the eyes lost 5 letters or more, which quite frankly in this disease state is not that surprising. 2 patients lost greater than 15 letters. So the big losers were very small. Here, in terms of OCT data, again, as I said earlier, these eyes were quite dry at presentation, and they stayed dry out to a year with the treat and extend regimen.
So, Diana, you see this data and you look at it in light of what we just talked about. And what are the key differentials you think in the range study versus what we just mentioned in the other ones?
Well, I think these eyes, they were already followed for a long period of time and received extensive number of injections. So by the time they enrolled in this study, as Lloyd mentioned, they didn't have that much disease activity. And then some of them required additional injections, but there was a range. And I think it shows that you can reach a point of stabilization, but you had to treat them aggressively for the first several years.
Quan, were you surprised by the distribution of the injections here, or is that sort of what you see in your own clinical practice, that there's just this wide, non-bell curve kind of approach to patients?
So as the graph shown on slide, Lloyd mentioned, there's a wide range of number of injection, and that's what I suspect also too, because just based on our own clinics, there's many different groups, many different pattern of patient, of subjects, of various groups. So it was not surprising to me that there's just a wide range. It would have been more surprising if I just only see like 2 patterns or just like 2 or 3 peaks. But here we see very much a bell shape, bell curve type of distribution, which is what one would expect also too in this population.
Lloyd, you were one of the primary architects of this study. I think it's interesting to see that fluid change there. So these people had dry retinas to begin with. So what do we owe the improvement in visual acuity to? We saw that in some patients when their OCTs were pretty bone dry in this case.
Well, we're in the process of evaluating some of the outliers, so the big gainers, the big losers. I mean, certainly there could be some confounding reasons for that. It's surprising that you would see big vision gains in an eye that's already dry. So I think there's more to come.
So we've really, I think covered the gamut as far as these trials go. So Quan, you look at these studies, what's unanswered for you right now? What do you think is still the burning questions from these sort of trials?
I would very much like to know, that the next time an individual patient come to me to see me, I can look at the patient, look at that, and perhaps able to perform some testing so I can predict how he or she can be doing. It would be great if I see Mr. Brown, I'm going to say, okay, based on what I'm seeing today, based on some of the analysis of the fluid I'm going to get from you or from blood from you, I can tell you that, yes, over a 5-year, this is what you're going to look like and what type of treatment you will need, and also perhaps what type of pharmacologic agent I'm going to use, and then how you would do. So additional study that all of us would love to do and see, would there be any type of either testing from ocular fluid, testing from genetics, to in a way put patient into category that we can help to predict. because that would be so great, so like biomarker, one would say, that will help all of us to be able to share with our patient what would they look like, because it's very concerning for them when they come to see us. They're very scared. They want to see, would they be able to see their children in the future or grandchildren in the future. Nowadays we can say, like we say, we're not going to lose vision, but then how long, how many more trips you're going to be getting this injection?
I think that's very interesting because if we're doing a good job with this, then we're probably, for a lot of our patients, over-treating them. You know, and I think that wouldn't it be nice to be able to figure out who those people
Exactly,
are?
yes.
Certainly, we're not doing people that were under-treating a service, but we're not. It would be nice to do it a little bit better for patients who are dry and doing very, very well. Maybe we could decrease the treatment burden. And I think that's a great point.
Yeah, Diana, you know, you've done a lot of research in this field. Do you feel like the lesion type has any indication on treatment frequency? So retinal angiomatous proliferation versus PEDs versus, what's your experience been in that?
Well, I think fortunately, any of these anti-VEGF therapies have great response, it seems, regardless of the baseline lesion. And in fact, now, as Lloyd mentioned, so many people are not using fluorescein angiography that probably half the retina specialists don't even know what the original baseline lesion was if they had not performed fluorescein angiography. But I think with confidence, we can say that if you treat these, whichever lesion aggressively, you're probably going to have a good benefit. So the baseline lesion probably doesn't play as big a role.
What about, like, for example, there's some evidence that say if you were to have a pigment epithelial detachment, a PED, for example, one pharmacological agent may be better or more effective than the other. Do you feel like, let's say, for the next patient to come in with a PED in your clinic, would you choose one agent over the other? Or
So I just finished a nice study, but I've seen a bunch of other studies done, and I'll tell you about our study, and then I'll talk about the other ones. We actually looked at volumetric quantification of this with the RPE elevation analysis, part of the software packages available in SDOCT, and looked at our own practice and saw patients from baseline with the 3 drugs and looked at them over time. Interestingly, people picked people with the highest PEDs to be on a Flibercept because they thought that that was the more effective drug at the time. And so there's a little bit of bias at baseline because the PEDs are larger in the Flibercept group. However, over the course of the study, all the drugs had an equivalent effect as far as PED resolution. So quite a nice way of looking at it in a quantitative fashion because you're looking at not only height or linear diameter, but you're looking at volume for the first time. And so it was a nice way of doing it. But you're right, the majority of people, I think, feel that one of the drugs is better than the other one, and certainly there's differences there. But so far, the studies have not shown that. I think across the board, we've seen a lot of those. You know, one sort of trial that has looked at that said, oh, because there's only one arm to the trial, it found some difference. But otherwise, there's really been no significant differences seen.
and I think that study is so important, the one that you're doing, and about hopefully to share that, because in particular, and I mentioned for the drug that we all know, like bevacizumab, where the cost differential is so great, and some of our patients, of our colleagues around the globe may say, well, I don't have this expensive name brand drug that may be better for this, but this study hopefully showed that it doesn't matter what you use. If you use any of this agent, that you still get the same beneficial effect. So that study will help to solidify that, yes, there's a role for any of this drug, any of the 3 agents that we have right now.
So that's a great question, Lloyd, for you maybe to bookend on that. You know, you have these patients in front of you, and now we're talking about diseases that last 7-8 years, and that has a huge cost differential. So how do you begin therapy in your practice? What drug do you pick, and what's your reason for picking it?
Well, so you know, fortunately, we have 3 good drugs, and we have a lot of experience with all 3 drugs, and so I think and we can feel comfortable about the safety of the agent itself, understanding that most of the issues related to the risk associated of treating patients with wet macular degeneration have to do with the injection procedure, and so that's very comforting. I think for me the only concern about using bevacizumab is this issue of compounding, and so if you're not hospital-based and you have to be very careful about your supplier of bevacizumab and have to understand how well they handle it. This whole the issue of compounding, I think, can be a problem, and so for my practice, we certainly use Avastin, and we use it quite frequently in primary treatment. But our concern about compounding has moved us a little bit farther towards using one of the branded drugs. And for me personally, I think either a Flibercept or ranibizumab are excellent choices, and I don't see a lot of differences in terms of acute therapy in the registration trials between the two.
Diana, same question for you. How do you pick the first drug when you set out on this now very long endeavor for these patients?
I think if cost is not an issue, then I tend to go with one of the FDA-approved drugs, either a Flibercept or ranibizumab. But a lot of patients do not have a secondary insurance, and the copay is significant. And if they can't have financial assistance, then bevacizumab, if it's compounded correctly, is a great alternative. But I think it's important that physicians do have the choice and not be forced to use a low-cost alternative just because it's less expensive.
Quan, people might say Flibercept and ranibizumab and bevacizumab are equal drugs. What would you say to that person about that statement?
I would say that yes, certainly based on clinical data, and we refer to one to the other. In other words, the cats, they look at bevacizumab and ranibizumab, but then we look at the view data that look at ranibizumab to a Flibercept. Then if we can connect one to the other and sort of like extrapolating, then yes, there may be similar data. It may be hard for one to say is exactly identical, but at least it's equivalent. However, I would then quickly also say, yes, one can start any subject on any patient on any of this drug, but make sure that one have an open-minded so that if he or she, the clinician that is, do not see or does not see the type of response that one expects, do not just keep the patient on that and have a low threshold to change the subject to a different drug, because we know that at the end we want the best outcome for the patient. So if we start out with drug A and patient doing great in drug A, then yes, continue with it. But if the patient doesn't show complete response, then should not base just that on the cost and then just keep treating the same thing.
Yeah. And I think we all expected that not to occur in the Protocol T study. We thought that, okay, these three drugs are pretty equivalent, and lo and behold, the Flibercept was a better drug for DME. And thus, I don't know if the transitive property as you're describing it really can exist here, because you're trying to equivalate all these drugs. Lloyd, one of I think the questions about these drugs come up, generally speaking, about how you begin to tell the patient that you might be switching, and when you decide to switch clinically. So let's start with the first part. You determining switching, and is it an early switch? Is it a late switch? When do you kind of go about that process?
As a treat and extender, if I can't get someone off of monthly therapy, if they've got chronic active disease on monthly therapy, after 3 or 4 injections, then I think it's time to move on. I think that's one group of people that you switch. That's probably a group you have to spend a fair amount of time educating the patient, because they may be getting better, but they're not getting better enough. The second group are people that are in more of a chronic disease, and you've extended them out, and then they have this recurrence of disease. I think we've all seen those patients where they seem to be doing well for a while, but for whatever reason they don't respond as well to therapy. And those are people that I tend to back the interval down and then tend to switch them if you don't get a treatment response. Those patients, I think, are much easier to counsel because they understand that things aren't going very well.
Mm-hmm. Diana, same question for you. Long-term, short-term, when do you decide to switch a patient for therapy?
I think that's challenging because there's no one right answer, and I think amongst all of us, we probably have different ideas of when we should switch.
At least 5.
Yes. Is it after 3 injections and we don't see a response, or is it after 6? And there's no consensus. For me, I'd like to see some type of robust reduction in fluid or edema at least after 4 treatments. If I don't, then I'm a little concerned, and maybe then I might do some additional testing to make sure that I'm not missing something, a masquerade syndrome, before deciding to switch.
Mm-hmm. Quan, do you ever switch patients late in the process? Have you found a situation in which you'd say, I've been down this road with this patient for 2 years, and now I've decided to switch? Was there anything in particular that might make you do that, or?
Well, certainly there are patients, but I have to say there are very few, and usually it has to be an event that make me feel like why we should switch. In other words, let's say the patient has been on ranibizumab for a number of years and he or she is very stable, then obviously there's no point of switching unless suddenly he or she on ranibizumab and suddenly develop a hemorrhage or some other aspect that doesn't seem to respond well, then I then have very low threshold to then switch to that one. And just like if we think of other aspects in medicine, for example, when we look at infectious disease, certain infection respond better to one antibiotics and not to the other. And so it will not be beneficial for the patient if the physician just adhere to one type of treatment and just watch the disease not improving.
Mm-hmm. So let's just go around one last time and give that one pearl to that treating physician out there who's watching this and tell them what you would say about long-term anti-VEGF therapy for AMD. Diana?
I think my pearl would be do not undertreat.
Mm-hmm. Great.
The study so far, what we have learned so far is that long-term treatment of anti-VEGF is relatively safe. There's no signal of anything that, at least from what we have learned so far. So yes, please continue to treat the patient as long as the patient needs it and not have to worry so much about the safety because we don't have any data to say that it's unsafe to treat long-term yet.
Lloyd?
Well, I think the good news is from the acute phase trials is that we see excellent outcomes with anti-VEGF therapy. We now have additional data to show that if we're persistent with treatment, you have consistent dosing, that we can maintain those gains. So don't give up on treating. These are great drugs. Use them for what they're designed for, and we can maintain good vision in these folks.
And I would just add that I think that for the patient's perspective, we can assure them that with proper follow-up and proper treatment, the majority of them will maintain or if not gain visual acuity in the long term. And I think that's an important point, especially for the patient who's trying to decide on how their lifetime is going to be affected by this sort of thing. I want to thank my colleagues tonight for joining me for this lively discussion on long-term anti-VEGF therapy, and thank you for being a participant and audience member in the Spotlight Retina program for this evening.